Okay, I think we're live now. So welcome to lecture, everybody, a virtual lecture today. I'm going to be saying a lot because I'm going to be figuring out what I'm talking to or what I'm talking about. It's not typical for me to be presenting to an audience of seemingly nobody, so it's kind of weird. But today we're just basically going to be going into the second half of the mood disorders lecture. I know Pan covered depressive disorders, major depressive disorder, in her lecture a couple of weeks ago. Now today we're going to finish that up by talking about treatments for major depression. And then we're going to move on to talking about bipolar disorders, and we'll get into a little bit what we're going to be talking about specifically as we go into that. But the other thing I wanted to say is just bear with me today. Like I said, this is my first time doing a video lecture. It feels very weird. I'm aware that my wife is in the next room over. I don't think she can hear me, but I'm feeling very self-conscious right now that she can hear everything I can say. If you do hear banging around in the background, it's probably my cats or something like that, scratching on the door trying to get in because they love me so much. Like I said, we're going to be talking about major depressive disorder, specifically treatments for major depressive disorder. I do anticipate that this lecture is going to be quite a bit shorter than it would otherwise in class, just because I'm not going to be taking questions, obviously, and there's going to be less back and forth, unfortunately. So my guess is going to be quite a bit substantially shorter than it would be typically. Following our discussion of, or my discussion of treatments for depressive disorders, major depressive disorders, we're going to be going into bipolar disorders, specifically talking about DSM classification, DSM-5, I should say, phenomenology in adults and youth, but we're going to try to spend a little bit more time on youth, even though it's not, the literature is not as robust there. We're going to be talking about prevalence, comorbidity, course of bipolar disorder. We're going to touch on some, briefly on some theories about etiology for bipolar disorder, i.e. what causes bipolar disorder. And then I haven't put it in here, but we are going to be talking about, treatments for bipolar disorders very briefly towards the end of the lecture today. Okay, so moving forward, I do just want to acknowledge that this is a very weird situation that we're all in for everybody. I'm assuming that most people in this lecture or in this class have never been in a situation quite like this before. I certainly haven't. I think this is day 8 or 9 of me staying in the house, or staying in my apartment, I should say. I've been out a couple times just for groceries and stuff, but this is kind of a surreal experience, and I want to acknowledge that I think everybody's probably working with slightly higher or maybe significantly higher stress levels than they were before. There's a lot of uncertainty and everything. Make sure that you're all taking time for yourself. And I know you've heard this a million times from a million different people, probably getting inundated with emails from the school about this. But we need to make sure that we're taking care of ourselves, and I include myself in that. Find a hobby if you don't have one already. There's all kinds of great opportunities online for learning new skills. Where are we? Right over here. I've recently restrung some of my guitars, so I'm playing guitar more. Picked up my crocheting again, so I'm going to be crocheting a weird campfire granny square sweater for myself. But whatever it is that you do, take some time for yourself and take care of yourself from a more clinical perspective or clinician perspective. I think it's really important to stress, given all the anxiety and stress that's coming along with this situation with the COVID-19. I really want to encourage everybody to take a break from news. Put down your phone, put down your computer for even an hour, 2 hours. If you can go a day or two without reading the news, it will do your anxiety quite well. There's a robust literature out there that shows that use of social media as well as more traditional forms of media in times like this can lead to significant increases in stress and anxiety, which often is going to just exacerbate the situation even further. If you're finding yourself getting too overwhelmed, feel free to reach out to some of the services available through Western. You still have access to counseling and so forth. Likely most of it's going to be virtual in nature, but it's still there, as well as resources for helping with relaxation and de-stressing, however that may look. I want to also acknowledge that there's a lot of uncertainty. We've been getting a lot of emails about the final exam I just yesterday posted a couple things, and Pam posted, I believe, a couple of things regarding the final exam, specifically with regards to the option of writing the final exam or not, and taking your final grade as being what you have after everything's in before the final exam. If anybody has any specific questions about that, please feel free to email Pan and or I, or Pan and I. I really want to request please be patient with us. We're trying to figure this out on the fly just as well as everybody else out there. And for that reason, sometimes we think we figured out all the possibilities or all the things that we need to figure out with the exam, for instance. And somebody will email us and point out that there is a shortcoming for an individual or for many individuals. And so we need to address that after the fact. So things might be changing more as we go forward. We're hoping to have more details in the next week or two about what the final exam is going to look like specifically in terms of length, how many questions, how much time you'll have to do it, and we'll go from there, okay? Yeah, like I said, if you have any questions or anything like that, send us an email. I'm also thinking about setting up some virtual office hours where either myself or Pan and myself will both have a link to a Zoom conversation or a Zoom session, and anybody that's interested can drop in and ask us questions about the exam, the course, anything like that. And that way you don't have to just email me out of the blue. We can have that set aside, okay? So everybody hang in there, take care of each other, take care of yourselves, and wash your hands, stay inside, please, please, please. All right, so let's get into the actual lecture itself. In terms of talking about major depressive disorder treatments, I won't go ahead and get into the disorder itself because you guys already talked about that, but really we're talking about a number of different forms of psychotherapy that have been shown to be effective for treating depressive disorders, major depressive disorder in youth and adolescents. And so these are mainly going to be cognitive therapy, cognitive behavioral therapy, and interpersonal therapy. So these are kind of your psychosocial or psychotherapeutic interventions that are widely used and have a good evidence base behind them. And then lastly, I've put this a little bit separate, is pharmaceutical interventions because they are also widely used. Now, we've talked about a lot of these things throughout the lectures, throughout the course this far, but I'm hoping to talk a little bit more specifically about how these work for major depression in the lecture today, given that this is kind of an area that I'm much more familiar with, so we can talk about the specifics in there as we get going, okay? So talking about cognitive therapy for depression specifically, this is largely coming out of, or the history of cognitive therapy in general. Let me mute my phone here. The history of cognitive therapy in general is coming out of Albert Beck and Dr. Albert Beck, I should say. He's a psychiatrist out of New York, I believe, but he's a giant in the field, and specifically with regards to treatment for depression, comes out of Albert Beck's cognitive theory of depression. And this idea is that people with depression develop or have cognitive biases or cognitive distortions with regards to the way they move through the world and interpret the world around them. These cognitive biases or distortions, whatever you want to call them, can often lead to what he termed as negative automatic thoughts. You'll hear that used a lot in cognitive therapy as well as cognitive behavioral therapy. And we'll go into more detail about these in a minute, but it's important to realize that these thoughts are not consciously used, or people don't purposefully, what's the word? Not purposefully. They don't decide to think negatively. It's in the word there, automatic. That they just happen. They happen with very little control. It's just kind of an individual's go-to to have these negative automatic thoughts in terms of the way that they interpret the world. So these cognitive biases lead to tendencies to have more negative automatic thoughts. And these automatic thoughts then manifest as negative beliefs or views about oneself, the world, and their future. or what we call the cognitive triad of depression. I'll get into that cognitive triad just a little bit more so that we can see it in more detail what it's all about. But first I wanted to talk about some of these cognitive biases or distortions. Now, there are dozens and dozens of different examples of cognitive biases and distortions, or negative automatic thoughts and the forms they come in. If you just Google negative automatic thoughts or cognitive distortions, CBT, you'll come up with lists and lists of them. This is a popular handout that's used in therapy just to explain to patients what we're talking about when we're talking about these negative automatic thoughts or these cognitive biases. And I encourage you to either pause the lecture or take a look at your notes and give these a read through in terms of what they are, as well as their names, as well as the definitions that are next to them, as well. Some of them have examples. For instance, all or nothing, or sometimes called black or white thinking. The idea is that when you're in a situation, there's really only two options. For instance, I'm writing an exam coming up. This is relevant for a lot of you. Somebody that's having a very biased way of viewing that exam is there's only two options. Either I'm a complete success and I get 100%, or I don't get 100% on this exam and I'm an utter failure and there's nothing I can do about it. I'm terrible. I'm stupid. I'm useless, etc., etc. Somebody that's depressed may be having these automatic thoughts or these cognitive biases, these all or nothing cognitive biases that lead to automatic thoughts of if I'm not perfect, then I've failed and I'm awful. Whereas I think anybody that's not in a depressive episode, or many people not in a depressive episode, would be more able to take a more balanced view of this situation. Okay, so instead of getting 100%, I got a 95%. Let's lower it. Either I get an 80% or I'm a failure. So somebody with a more balanced approach to this would look at this and say, well, I got a 77. That's not really what I was hoping to get. I really worked hard. There were some areas where I could have studied more effectively, and some of the questions I found confusing. So just because I didn't get an 80% doesn't mean that I'm useless and terrible and stupid. Rather, it means that I didn't perform the way that I wanted to perform that day, or maybe the test was too hard. It was unfair in some way. So looking at alternative explanations besides if I don't get an 80, I'm terrible and useless, stupid, etc. You have mental filters, so only recalling or noticing certain types of evidence. So for instance, let me think of an example of that. Somebody you didn't get the job interview for the job that you really wanted. Now you got 4 other interviews for other jobs that were less important to you, but because you didn't get that interview for the one job that was like your number one preference, really focusing on failing at that aspect, not getting the interview for that job, and not weighing this other evidence that you have that, oh no, I am actually capable. I got 4 job interviews for decent jobs. It just happened to be that I didn't get the first choice that I had. Somebody with this mental filter or this mental block might only focus on that one piece of evidence that shows that they're a failure. I didn't get that one job interview. They'll discount all the other evidence that they have about those 4 other interviews they had. They'll ignore those when they're talking about it with people or thinking about themselves or about the world or about their future, and just focus on their one failure, the one piece of information that confirms to them that they're a failure. I'm not going to go through any more of these, but just to know that there's all kinds of different cognitive biases that can contribute to people having negative automatic thoughts. Just give me a second here. Excuse me. Let me see, do I have anything else I want to talk about there? No. So this is what we're talking about when we talk about the cognitive triad. You'll see this depicted in many different ways. Sometimes you'll see it with like lines with arrows pointing to each other. And then I've also seen it in this triangle shape. I like this triangle shape. And it really talks about people with depression have a series of cognitive biases that are focused on 3 main areas. So this so-called cognitive triad of depression. That's negative thoughts about the self. They have negative thoughts about the future, and they have negative thoughts about the world. And all these three of these together, and now one individual may have more of one than the other. One individual may not have any negative thoughts about the future necessarily, but typically we're going to see all three together. And this pattern, this ongoing pattern of three forms of negative thoughts about self, future, and the world contribute to the syndrome that we know as depression, or the disorder that we know as depression. And the idea being that these negative thoughts, and especially importantly, is these negative automatic thoughts that just come up for us without, they're kind of our go-to, contribute to negative emotions as well. If we're going about our lives and every single interaction we have, every single thing that we do in the world is viewed through a belief that we're a bad person, we're useless, we're stupid, things are never going to get better, so that's negative. So sorry, let me go back for a second. I'm a bad person, I'm terrible, I'm stupid, I'm useless, negative thoughts about myself. And because I'm these things, let's say, I don't see any hope for the future. The future is always going to be like this. I'm never going to be able to get better. I'm never going to be smart again, or I never was smart in the first place, but there's no future hope for me. These are negative thoughts about the future. And then this world is a terrible place because nobody's able to give me any help. Nobody wants to give me any help. The world's generally an awful place where awful things happen all the time. If I'm going through the world thinking this way on a regular basis, not because I want to, but it's an automatic pattern of thought, well, it's not too much of a stretch to see why somebody would start having negative feelings as well, either shortly after or directly as a consequence of these negative thoughts. If I'm constantly interpreting everything I do and everything in the world and my hopes about the future through a negative lens, I'm going to start having feelings of hopelessness, sadness, distress, anxiety, things like that that are associated with a major depressive episode. And I'm going to become less motivated to do the things that I want to do. So this is the theory, the cognitive theory of depression. So with regards to how we're going to treat depression from a cognitive approach, we're going to be looking at the focus is on those depressive thoughts and the depressive thoughts that are characterized by the cognitive the cognitive triad of depression. So the goal is, I should say as well that you'll variously hear thoughts or automatic thoughts referred to as beliefs, attitudes, cognitions, all kinds of different terms for this. But the important thing is that we're talking about cognitive therapy is focused on the level of thought or cognition. The goal is to identify maladaptive or negative automatic thoughts. And this is done via a collaborative process between the therapist and their client. The therapist typically will start with psychoeducation, or it's just a fancy way of teaching somebody, so teaching their patient about the cognitive theory of depression, like I just did with you. I would spend much more time with a patient and make sure that they understand appropriately and have them explain it to me afterwards to ensure that we're on the same page with regards to what that theory of depression is. And then they're going to work with the client, the therapist is going to work with the client to identify potentially maladaptive thoughts that could be contributing to their depressed mood. Together, they're going to work on challenging these thoughts. So this will typically, like the most classic example, this is by no means the only approach to use, but you'll see people use thought records. So let's write down a list of situations, interactions, scenarios that you found yourself in as the patient that you believe are making you feel sad, disinterested, unmotivated, etc. Or maybe let's talk about situations that you found yourself in recently that have been problematic for you or challenging for you. Oftentimes people will talk about rejection or feeling useless, feeling stupid, things like that. And we want to tool that with the patient and really emphasize that when we're talking about I felt stupid or I felt useless, those aren't feelings. There's only really 5 feelings: happy, sad, angry, disgusted, and fearful. But when we're talking about things like I felt useless or I felt stupid, we want to rephrase that with the patient. Okay, well, that's a thought you're having. You had the thought, I'm stupid. You had the thought, I'm useless. How did those thoughts make you feel? Well, they made me feel sad. They made me feel angry at myself. And we'll spend some time distinguishing between those thoughts and those feelings, because a feeling's not so easy to change necessarily. It's hard to challenge somebody's feelings. You feel sad, don't feel sad. That's not helpful. However, if we were to say, okay, I had the thought that I was stupid. Okay, let's treat that as a theory. Now let's gather evidence, or let's investigate the evidence together, both as the patient and the therapist, and see what evidence there is to support the idea that you are stupid, that that thought is correct, because maybe it is. I probably wouldn't put it that way with a patient, but you get the idea. After that, we're going to go through looking at all this different pieces of evidence for the thought that they're stupid, and then we're going to look at all kinds of disconfirming evidence that goes against the idea or the thought that they're having that they're stupid. Okay, I had this thought, this belief. So when I personally am in a depressive episode, I often have the thoughts, automatic thoughts, that I'm stupid, I'm useless, and any day now I'm going to be out of a career and I'm going to be living in the street in no time, and nobody will want anything to do with me ever again. These are not realistic thoughts, they're depressed thoughts. Now, if I sit down with a therapist and I'm asked to challenge these thoughts, I can come up with all kinds of evidence to support this, but I'm going to be able to come up with much more evidence to go against this. If I was stupid, I probably wouldn't be working on my PhD right now. I probably wouldn't be having success in my PhD. If I was useless, I probably wouldn't have people asking me to help them with different things or to teach them different things, et cetera, et cetera. These are all pieces of evidence that you can't argue with. Why would people do this otherwise? So we're going to be going through with somebody to challenge these thoughts, just like that. And again, that's a really brief overview of it. It's going to take a lot of work with somebody to do this, but that's generally the idea. Following challenging these thoughts, we're going to work with them to modify these maladaptive thoughts or these automatic negative thoughts so that they're more realistic and adaptive. So this is going to be talking about, okay, so now that we have all this evidence for, and more importantly, all this evidence against for these automatic thoughts that you're having, I'm stupid, let's kind of weigh them against each other and see, okay, well, if you look at this and you believe this to be true, or you use this evidence to say that you're not stupid, how would that make you feel? Well, I'm a lot less sad. Maybe I feel actually a little grateful that people are reaching out to me and asking for my support or asking for guidance on different things. I appreciate when people do that. Okay, and so what's maybe a more realistic thought that you could be having, because maybe you missed that deadline or you didn't understand something, so you felt stupid in that situation. You had the thought that you were stupid in that situation, that made you feel sad, but you have all this other evidence to show that you're not necessarily stupid all the time. What's a more adaptive thought? Well, sometimes I don't understand things as well as I'd like to, but for the most part, I do all right, and I'm a fairly intelligent person. That'd be a more adaptive thought. That's more positive, it's more realistic. And the idea throughout cognitive therapy is that we want to shift it away from these negative automatic thoughts that are often focused on, I'm a bad person, I'm useless, I'm stupid, I'm ugly, I'm whatever, to something more realistic, that sometimes I have these feelings, or sometimes I'm in situations where I do feel, or I do have the belief that I'm very stupid, and there's evidence to support that. But more often than not, I do understand things, or even some of the time I do understand things, so I'm not stupid all the time. So we want to shift to a more realistic perspective of the world. And we want to teach people to do this themselves, both identifying these thoughts, challenging these thoughts, and then adapting them or modifying them, so that we will work together with the patient for quite a long period of time and slowly kind of get them to develop their own challenges and their own ability to identify these thoughts, so that eventually they can move out of therapy after about hopefully 12 to 14 weeks and be able to continue to use these skills in their own life outside of the therapy office in a way that allows them to treat or prevent future depressive episodes. Here's just an example. I pulled this from the textbook and I modified it a little bit, but you might have a situation, for instance, you ask a friend to get together after school, but they say they can't because they have too much homework to do. Now, an irrational or automatic negative thought might be, you think, well, my friend won't get together with me. She obviously doesn't like me and she'll never want to do anything with me again. I feel that'll leave you feeling rejected and sad often. Now, if we were to challenge this thought, somebody with depression might be having this irrational thought or this automatic thought. Somebody without depression might be having it as well. But the idea is that somebody without depression might be able to more easily either just move on from that thought and the negative feelings that come with it, or are more able to adapt it to a more rational belief or rational way of thinking, more adaptive way of thinking. So for instance, well, she's busy today, but we can get together some other time. She's still my best friend. Sometimes I'm busy and I'm not able to do things because I have too much homework to do. That doesn't mean I don't like my friends. And that's a more balanced approach to this. So that's cognitive therapy for depression. That's the main approach there. With regards to behavioral therapies for depression, they're largely emerging from Lewinson's behavioral therapy of depression. And this is the idea that depression follows a loss of some sort often. Depression often follows a loss of some sort, whether this be a death, rejection of some sort, either by another person or by an organization, a school, something like that. Some type of failure or perceived failure, or the loss of a social network or something like that. So following these situations of loss, the individual has less opportunities for reinforcement for productive and adaptive behavior. If you've got a death or a rejection or a failure, you're not getting reinforcement for behaviors that you usually engage in because you've lost that opportunity for reinforcement. I don't think I'm explaining this very well, so if anybody's confused, please email me or message me or something. But I can, top of my head, I can't explain it any better right now. Along with this reduced reinforcement for productive and adaptive behavior, there's an increased reinforcement for depressive behaviors. It feels good to lie at home and feel sad when you're sad. It feels good, let me rephrase, maybe it doesn't feel good. It's easier at times to do that. It feels easier in the moment to not get out of bed. It feels easier in the moment to not reach out to other friends and maybe experience another loss of some sort. And because that, you get this reinforcement. Now, behavioral therapy, reinforcement for depressive behaviors, I should say. Behavioral therapy focuses largely on increasing opportunities to receive appropriate reinforcements for adaptive behavior. So a lot of times this will start out as reacting to a loss, and it's normal to feel some form of grief or something in reaction to a loss of some sort, but it kind of continues for a longer period of time. And if that's the case, oftentimes when I sit down with somebody that I'm assessing for depression, especially when I'm going to be doing treatment with them, I ask them about their interests. What do they like to do for fun? And oftentimes they'll have a hard time coming up with ideas of what they do for fun. And I'll ask them, okay, well, let's talk about maybe a year ago when you weren't feeling this way, or the last time you weren't feeling this way and you felt more yourself. What kind of things did you do for fun? Oh, well, I love to play guitar. I really like to paint. I used to always go on runs, and I love doing that. I like to get together with my friends for dinner. We used to watch movies all the time together. Okay, so when's the last time you played your guitar? Oh, it's been 4 or 5 months. When's the last time you got together with your friends? It's been like a good 3 months kind of thing. And they'll list all these things that they find rewarding and reinforcing or previously rewarding. And they'll realize that they haven't done a lot of those things, or they're doing them a lot less regularly than they are. So what we'll do with behavioral therapy often, or one of the main forms of it, is called behavioral activation. We're going to say, I want you to make a schedule of when you're going to do these things that you previously found to be reinforcing, or things that you enjoyed before. It's not going to be easy. You're not going to feel like you want to do it in the moment, but I want to make an agreement that you're going to do these regardless of whether you're feeling up to it or not. And the idea is that by changing our behavior and engaging in more active forms of behavior of things that we enjoy doing or previously enjoyed doing, you're going to have more opportunities for reinforcement of positive adaptive behavior. The evidence out there is that behavioral activation is one of the most effective forms of therapy for depression. the difficult thing is getting people to actually comply with it, because when you're depressed, you don't really want to do anything. And the idea that somebody's saying, well, I know you don't want to do anything, but I'm going to ask you to go and do all those things that you hate the idea of doing right now, and it's going to make you feel better. It often takes some time before people start seeing any improvements. And for that reason, it's hard to get some buy-in for this, but is one of the main approaches for behavioral therapy. Cognitive behavioral therapy, we're talking about the integration of cognitive and behavioral interventions into one school of therapy. Now, CBT, cognitive behavioral therapy, is much more typical than a pure behavioral or cognitive intervention, both in adults and children. In the text, there's brief descriptions for, in the textbook, there are brief descriptions for various manualized CBT approaches for treating depression in children and adolescents. I encourage you to go through and have a read through of those things. I can't think of what the actual names were, but they're just different, like I said, manuals for implementing CBT. Although there's differences in how these different approaches or different manuals approach CBT for depression, there are typically more similarities across them than there are differences. It's just different people implementing it in different ways, focusing a little bit more on different behaviors, depending on the manual that you're using. So the idea with CBT is that you're going to take the cognitive aspects and identify, challenge, and modify maladaptive thoughts and beliefs, and then you're going to also incorporate behavioral aspects to increase opportunities for reinforcement of non-depressive behaviors and generally reduce opportunities for reinforcement of depressive behaviors. Most of the behavioral aspects are typically done via homework exercises outside of the therapy session. Now, that's not to say that you're never going to do a behavioral exercise in the session, but that's just typically how it splits, is a lot of the cognitive work is done in session, and then we're going to be encouraging people to do it out of session as well, but a lot of the behavioral work is going to be done in their day-to-day life on a regular basis. Okay, so that's behavioral therapy, cognitive therapy, and CBT. Let's get into briefly interpersonal therapy for adolescent depression. Now, this is one of the schools of therapy that is not one of the cognitive behavioral ones that does have some robust evidence supporting its use. It's empirically supported for treating depression in both adolescents as well as adults. Now, with regards to interpersonal psychotherapy or ITP, we're talking about kind of the focus is on the idea that depression is caused by and causes disruptions in social relationships and interpersonal relationships. Now, it's not necessarily the case where somebody will say, as far as I understand, this is where it starts, or this is where it starts, but rather that in general, depression is characterized by changes in interpersonal or social functioning. For instance, losing somebody, losing a relationship, or having relationship troubles, and this leads to depressive symptoms, which then these disruptions in social relationships and the depressive symptoms that they bring up, the depressive symptoms lead to further degraded social functioning. So if you had some kind of loss, or you're arguing a lot with your partner or your friends or whoever, your boss, and you have an increase in depressive symptoms, those depressive symptoms are going to impact on your other social relationships and your other interpersonal relationships, causing more strife and leading to more poor social functioning, or increased or decreased social functioning, which increases stress and the depressive symptoms. And it's kind of this vicious cycle. So what ended up happening is people withdraw from social situations, or maybe engage in really maladaptive social interactions that just exacerbate the depressive symptoms, and it just goes on and on. Now, the idea with IPT for adolescents is it's going to be focusing on the way that the adolescent or the patient, or changing the way that they relate to others in order to improve interpersonal functioning and thereby increase social rewards and alleviate depressive symptoms. So a lot of this is going to focus on social skills training. So this is going to be specifically to people that it's evident that they have personal deficits in the way that they interact with other people or their social abilities. Sometimes people just aren't good with holding a conversation or aren't good with recognizing emotions in other people. And social skills training is going to work with individuals to bolster those abilities and teach them how to more appropriately interact with individuals or groups. It's also going to involve role-playing specific interpersonal problem areas. So if you have an adolescent that comes into your office for IPT and they're talking about, I'm always arguing with my mom and I feel like garbage because I feel like she treats me like crap all the time, she doesn't understand me. There's going to be role playing between the patient and the therapist in terms of how do we navigate this relationship? How can we change the way that you're acting in order to change the other person's behavior and change the way that this social or interpersonal relationship is happening and hopefully nudge it to be a more positive and adaptive approach to interacting with other people in your life. And then finally, it's going to involve improving problem-solving skills. That's both socially and just personal problems. A lot of times people with depression are becoming overwhelmed at every even relatively minor issues, and they lack or have lost the ability to effectively problem solve. So it's going to be some very basic problem solving strategies in there as well. But these combined, and again, this is a gross overview of interpersonal psychotherapy. You can take courses and indeed whole careers are based around understanding IPT, but these are generally the areas that we're going to be focusing on with the idea to improve interpersonal functioning and increase social rewards and eventually relieve depressive symptoms. So moving on from there, we're going to move off from psychotherapy approaches and talk more about medication and psychopharmaceutical treatments for major depressive disorder. Now, the main line in terms of medication treatments for major depressive disorder is SSRIs, or selective serotonin reuptake inhibitors. Now, you should know that SSRIs are a class of medication that work by blocking reuptake of serotonin, which is a neurotransmitter. So it blocks reuptake of serotonin in the presynaptic neurons. So generally what you have is you have a presynaptic neuron and a postsynaptic neuron. The presynaptic neuron is going to be releasing different neurotransmitters to communicate with a postsynaptic neuron. Now, what happens with an SSRI is it's going to prevent the presynaptic neuron from taking back up the neurotransmitter that it's released, serotonin in this case, so that it's got more of a chance to bind to the postsynaptic neuron and communicate with that neuron. So the idea is not that it's releasing more, it's that it's not taking these neurotransmitters back up as quickly, and that way they have more of a time and more of an opportunity to actually activate the postsynaptic neuron. There is evidence that these are fairly effective for treating depression, both in adults as well as youth. That said, most of these medications aren't actually approved, at least in the States. I believe in Canada as well. Most of these medications aren't actually approved for treatment with children or youth depression. That doesn't mean they're not used. It just means that they're not indicated. The official line from the government is that these are not supposed to be used, or they're not necessarily supported for use in treating adolescent or childhood depression. But many many doctors still prescribe these what's called off-label, which means you're using this drug in a way that's other than it's intended to be used. So because there's not a whole lot of research support, there's less research support for their use in children and adolescents. We can't officially say that this is a treatment of choice, yet it's widely used. I believe fluoxetine or Prozac is the only medication or SSRI that's indicated for use in children and adolescents, at least in the States. But all of these different SSRIs are used regardless of whether they're supposed to be used that way. Now, the other thing to know is tricyclic antidepressants, which are also widely used in adults, less so than SSRIs, but still widely used. They've been shown to have little to no benefit for youth with depression. And in fact, they've been associated with some severe cardiovascular side effects. So this is not to say that they're never used, but rather they are not typically a primary form of treatment. It might be that somebody will be prescribed a tricyclic antidepressant after they've gone through several rounds of different SSRIs and there was no positive effect, then they might move on to a tricyclic. But rarely, if ever, will you see somebody start on a tricyclic as a youth or an adolescent with depression. The other thing I want to talk about real briefly is with regards to medication treatments for major depressive disorder is that they're associated with an increased risk of suicidal ideation. You'll see that as a black label warning on pretty much all of these drugs. That said, from what I've seen, and I did a little bit of research outside of the textbook as well, the risk remains fairly modest. With regards to a meta-analysis that I read, as well as another study that was published around the same time of 1,500 children. So the meta-analysis, I think, covered about 4,500 or 5,400 or something like that children. And this other study studied about 1,500 children who were either given an antidepressant medication, typically an SSRI, or a placebo treatment, so a sugar pill, and they were double-blind studies typically. What we saw was maybe 1 to 3 children who were treated for every 100 that were treated would experience an increased suicidality beyond what's expected due to depression alone. Now, this is not to say that they were more likely to engage in suicidal behavior or attempt suicide, rather that they were more likely, 1 to 3 for every 100 were more likely to experience suicidal thoughts or beliefs, ideas, if that makes sense. So the risk is there, but it seems to be a relatively minor risk, especially when you counter it with maybe the consequences of not getting treatment and how that can impact on an individual's life and the challenges they might be facing. Okay. So we're going to move on to bipolar disorder. I know I said this was going to be a short lecture, but I feel like I'm moving fast and it's still taking a lot of time, so sorry about that. So bipolar disorder, we're going to talk about classification, phenomenology, prevalence, comorbidity, course, and etiological theories, as we have with every other disorder that we've been looking at this year. So bipolar disorders, there's a couple different bipolar disorders. We're going to mainly talk about bipolar 1 and bipolar 2 today and talk about the differences therein, as well as how they manifest differently in young children versus adolescents and adults. Now, one of the most important things you need to know about bipolar disorders and what sets them apart versus other disorders in the DSM is that bipolar is characterized by the presence of mania symptoms, specifically manic episodes and hypomanic episodes. And we'll get into what that is in just a second. I want to also mention that you might hear this called manic depression sometimes. This is what it was once called several DSMs ago. This term is very archaic, very old now. I've never heard it used in a professional setting, but you might come across it every once in a while if somebody's talking about their manic depressive or they had manic depression or something like that. Typically what they're referring to is a bipolar disorder, whether it's bipolar 1 or 2. Okay. So a manic episode is characterized by a couple of things, principally a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy lasting longer than 1 week, 1 week or longer, I should say. So you have to have at least 7 days where this is happening almost or most of the time every day. Of this persistently elevated, expansive, or irritable mood and abnormally and persistently increased activity or energy. This time period is important because that's one of the distinguishing factors between mania or a manic episode and hypomania / a hypomanic episode. I want to also point out that we're talking about with both a manic episode and a hypomanic episode, there's a reason they say distinct period. This is not somebody's normal state. So if you have somebody that is generally always very elevated, expansive, or irritable, and they generally have a lot of activity or energy, this does not mean that they are experiencing a manic episode. It has to be distinct and different from what their normal way of moving about the world is. These are episodes. They're not lifetime, okay? In addition to having criteria A that we just talked about, During the mood disturbance and increased energy activity episode or period of time, you're going to have at least 3 of the following. Either inflated self-esteem or grandiosity. When we're talking about grandiosity, you sometimes heard them referred to as delusions of grandeur or grandiose delusions. These are people that maybe, as an example, would believe that they have a special relationship with God, or they have superpowers, and not like they're pretending they have superpowers or they would like to, or that they're very religious, but rather they believe that they have a direct communion with God. They can speak to God on a regular basis, or they aren't pretending that they're one of the X-Men. They are Wolverine. They know they're Wolverine. They can shoot, or that they can't die, kind of thing. Things like that. That'd be a delusion of grandeur. You may have decreased need for sleep, typically feeling rested after only 3 hours of sleep, and not like, I can still keep going after 3 hours of sleep. You're still really energetic, you're really active, and you only need 3 hours of sleep to still feel super energetic and rested. And this is happening for multiple days in a row. Excess talkativeness or pressured speech. So you'll have people that, it's almost like they're tripping over their words. They can't speak fast enough. They have so much to say and they just want to get it out. Flight of ideas or subjective experience of racing thoughts. So this might be your ideas are kind of bouncing around really fast, or you're just having so much of them move through your head so fast that you can't keep up with your own thoughts. That'd be somebody that's having a flight of ideas or racing thoughts. Excessive distractibility, so it might be like little things around the room are constantly distracting them. Their thoughts are distracting them to the point where they're not able to focus on what they need to be focused on. Number 6, increase in goal-directed activity, whether this is in social areas, work or school / occupational areas, or sexual areas. Now you'll see sexuality and sexual activity is often talked about in bipolar disorder, as well as manic episodes, hypomanic episodes, because it's often manifested, or I should say often manifested. It's not unusual to see it manifested here. So with regards to that, we're talking about things like maybe becoming overly sexual in your interactions with people, maybe engaging in a lot of promiscuous sex outside of what would be normal for that person, maybe compulsive masturbation or something like that, as well as, or psychomotor agitation. So this is like physically just needing to be on the go, having a difficulty sitting still, kind of pacing the room, things like that. And then finally, we have, as one of these potential symptoms, is excessive involvement in activities with high potential for negative consequences. This is a pretty typical hallmark of bipolar disorder. With regards to this, we're talking about unrestrained buying sprees or spending sprees. So maybe like if you're making, I don't know, your income is $30,000 a year, you're going out and buying yourself 3 new jet skis, and then going and buying a whole new set of wardrobe, and then going out buying a new car, things like that. That are way beyond what you could reasonably afford, and it's actually dangerous for you to be spending all this money because it's going to leave you without anything. In addition, with regards to high potential for negative consequences, activities like that, we're talking also about sexual indiscretions. So this might be somebody walking around outside naked. It might be somebody inappropriately making passes at many different people. It might be people, like I talked about, sexual promiscuity beyond what is typical for that individual. And I mean, I don't need to get into why that might cause trouble. Sometimes people will be in relationships already, and they're going out and they're sleeping around, or they're engaging in sexual acts with other people, and they wouldn't typically do this, but because of being in a manic episode, they're not necessarily thinking about the consequences of these behaviors. And then, so the only other thing I want to talk about a manic episode here specifically is I really want to emphasize that this represents a change from the person's normal behavior. So again, if you have somebody that's generally sexually promiscuous to begin with, more power to them. This does not necessarily mean that they're manic or having a manic episode. This is where you have somebody that's not typically engaging in promiscuous sexual behavior, but has a distinct period of time that's lasting a week or longer where they're doing a lot of this. Or for instance, engaging in a lot of, you might have somebody that's generally speaks a lot, myself, or has pressured speech, again, me at times. I've never had a manic episode though. This would be somebody that's not typically engaging behavior like this, or if my talkativeness went way beyond what is normal for me, okay? The other thing I want to talk about is people in a manic episode often have very poor insight into the fact that what they're experiencing is abnormal. So you might, somebody that's having a manic episode might be feeling great about themselves. Not always, but they might be feeling great about themselves and think that they're able to do all these things and this is a normal thing for them. Whereas anybody else that's witnessing this happening is going to very quickly realize this is not usual, this is very abnormal, it's kind of frightening at times, at the very least concerning. But because the individual with the experiencing the manic episode has poor insight into it, they often resist treatment, or they deny that they need any treatment because they're not aware of that. They think what they're experiencing is normal and it's great. However, it comes with a lot of negative consequences, both to the individuals and other people, or it can come with a lot of negative consequences. So we want to get them in for treatment as soon as possible. I think that's everything I want to talk about there. Okay. With regards to a hypomanic episode, hypo is Greek for under. So I really want you to think about hypomania or hypomanic episode as being a less severe, there still can be very severe, but less severe than a manic episode. So a hypomanic episode is characterized by a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally increased activity. So very similar, if not identical, definition to manic episode, except this is lasting for greater than or equal to 4 days in length, whereas a manic episode was greater or equal to 7 days in length. Criteria B, in terms of the symptoms that we're talking about, are the same as what we saw ahead with the manic episode. So same types of symptoms, same number of symptoms are required. However, there's a criteria C here for a hypomanic episode in that it's associated with an unequivocal, so an indisputable change in functioning, uncharacteristic of the individual when they're asymptomatic. In addition, the mood disturbance and change in functioning is observable by others. So this might not be to the point where, in fact, it's not to the point where they need immediate hospitalization or something, but it is something that others around them are going to recognize that, oh, this is not typical for this person. They're acting strangely or differently than they typically would, okay? And like I said, the episode's not severe enough to cause marked impairment in social or occupational function or to require hospitalization. And I should point out that anytime we're talking about psychotic features, so somebody that's having very strong delusions or hallucinations, by delusions we're talking about very bizarre beliefs and thoughts, that's requires hospitalization typically, and we're talking about a full manic episode in that case. Similar to, or similar for both manic and hypomanic episodes, they can't be due to another mental health condition or physical condition or due to substance use. So if you had somebody that just went out and smoked a whole bunch of meth and they're having these symptoms, that would be probably a manic episode or a hypomanic episode due to a substance it'd be a substance-induced manic or hypomanic episode. So in order to be a pure manic or hypomanic episode, you can't have it be caused solely by a substance or another condition. So really quickly, I just want to go over the differences here between mania and hypomania, compare the two. The most obvious one here is just the differences in terms of how long the symptoms have to be going on for. For a manic episode, it has to be at least 7 days in length, whereas for a hypomanic episode, it's got to be at least 4 days in length. So less time is required for a hypomanic episode. In terms of impairment, for mania, we're talking about severe impairment in social occupational function. They're not able to do the things that they would typically be doing due to their symptoms. For hypomania, they still might be experiencing some impairment, but it's not going to completely inhibit their ability to engage in their social or occupational roles. For mania, it may require hospitalization. As soon as you do have hospitalization due to those symptoms, the manic symptoms, it's automatically determined that it's no longer hypomanic, it's a manic episode. Hypomania, no hospitalization is required. So you can be hospitalized, but if it's for something else, not specific, like if you've broken your arm or something like that, that's not necessarily, doesn't increase it to a manic episode automatically. It'd be more like if you're having so many symptoms of mania that requires you to go to the hospital, that would be what we call a hospitalization due to mania. In addition, hypomania, you can't have psychotic features, whereas mania, it may have psychotic features. So if you're having a kind of manic or hypomanic symptoms, but then you have these psychotic features, like I talked about, delusional thoughts or hallucinations, as soon as you have those, it's now considered a full manic episode, okay? I should have moved this, I'm so sorry. Hopefully you can see from your own slides. Now I'm going to check that every time. All right. So let's talk now about, so that was manic episodes and hypomanic episodes. We haven't really talked about what bipolar disorder is. So in order to have bipolar disorder, you need to have experienced either a manic episode or a hypomanic episode. There's some other criteria here as well that we'll go through in just a second, but that's the real distinguishing thing about bipolar disorder, is the presence of mania or hypomania, okay? So with bipolar 1 disorder, you have to have met criteria for at least one manic episode, okay? As soon as you've experienced one full manic episode, you now meet criteria for diagnosis of bipolar disorder, unless the symptoms were better explained by one of these other disorders. But as soon as you have that one manic episode, bam, bipolar 1. For bipolar 2 disorder, you have to have met criteria for at least one hypomanic episode, okay? You also have to have met criteria for at least one major depressive episode. Typically, these will happen before you see a hypomanic episode. Not always, but typically. You also must have no history of a full manic episode. So again, if you've had a hypomanic episode as well as a major depressive episode, and you're diagnosed with bipolar 2 disorder, as soon as, if in the future you go and experience a full manic episode, you no longer have, or considered to have had bipolar 2 disorder. You're now considered to have had bipolar 1 disorder, and it was just misdiagnosed, okay? So at least one hypomanic episode, at least one major depressive episode, and no history of a manic episode. Also, the occurrence of either a hypomanic episode or a major depressive episode are not better explained by these other disorders. Now, I do want to point something out here. For bipolar 2, you need to have both the manic side of things, hypomanic I should say, as well as the depressed side of things, the major depressive episode. For bipolar 1, you do not necessarily need to have a major depressive episode. However, most individuals, the vast majority of individuals with bipolar 1 disorder will have experienced or will experience a major depressive episode at some point in their life. Approximately only 15% of individuals have what's called unipolar, so one unipolar mania. That's to say, will have manic episodes without any major depressive episodes. It's exceedingly rare, okay? With regards to bipolar disorders in children, and specifically the DSM-5 criteria, contrary to what we saw with some other mood disorders like major depressive disorder, there's no specific criteria for children. There's no modifications of the criteria for children. And so this can be kind of problematic in that if you're going to be diagnosing young children, let's say an 8-year-old, with regards to those manic symptoms or those hypomanic symptoms, some of those symptoms are going to be relatively normative for children, as opposed to they wouldn't be normative for adults. So for instance, let me see here. For instance, a child, like, it's not unusual for children to believe that they have special powers or something like that. However, we're talking about a prolonged period of time where maybe the child will be putting themselves in danger because they believe that they could jump off a building without dying, or they could fly or something like that. You still will have some kids, some like 8-year-old kids, 7-year-old kids, that jump down the stairs because they thought they've been watching a lot of Superman and they thought they could fly. This does not necessarily mean that it's a manic symptom. It's just a kid being a goofy kid and not thinking through the consequences. Well, we're talking about with a bipolar disorder is something that's more prolonged. But the problem with these definitions here is it doesn't take into account some of these normative experiences of childhood, and for that reason, it can be unclear to some clinicians, and many clinicians, I should say, what is considered a normative behavior for a child versus what we would consider a manic symptom in a child. And for this reason, it kind of complicates diagnoses, if that makes sense. I want to talk about briefly about phenomenology with regards to bipolar disorder in general, and then we'll talk about more specifically in children. Among adults, approximately 60 to 70% of manic episodes occur close in time to depressive episodes, either immediately before or immediately after a depressive episode, or maybe in the midst of a depressive episode. We have what's called mixed episodes. This is a specifier that characterizes when there are full criteria for a major depressive episode. So if somebody's in the middle of a major depressive episode and they're also experiencing simultaneously 3 or more manic or hypomanic symptoms from the criteria B. Let me go back to that. For these ones here, so 3 or more of these in the midst of a major depressive episode, okay? So they're happening at the same time. We would call that a mixed episode, okay? And it has to be persistent throughout the episode that you're experiencing both simultaneously, okay? Rapid cycling refers to instances when individuals have 4 or more distinct episodes of mania, hypomania, or depression in a single year. So this would be they have a manic episode, they recover, then they have another manic episode, then they recover, and maybe they have a depressive episode and they recover. And that happens at least 4 times that you have, I believe it's like 2 weeks or maybe a month in between these episodes where you're not experiencing symptoms of or full criteria for an episode of depression or mania or hypomania, okay? So the big thing that I want to emphasize here for all bipolar disorders, dramatic pause with my team, is that there's recovery in between episodes. So even though this is often a chronic disorder in the sense that people relapse and have repeated episodes of mania, hypomania, and often depression, in between those episodes, they return to a more normal level of mood. So they're no longer way up high with their mania or their hypomania, or very low with their depressive episodes. There's in between times, in between episodes where they're having a more normative mood, if that makes sense. That's essential for bipolar disorder, that it's this shift between different states, okay? Let's talk briefly about bipolar disorder in children, specifically. It's sometimes referred to as pediatric bipolar disorder. It's important to talk about this because it doesn't, when we're talking about specifically pediatric bipolar disorder, it's thought to not resemble classic bipolar disorder that we talk about in adults. Now, this is where a lot of the research has been done, has been in adults, and a lot of the characterization of bipolar disorder is in adults. And I should say late adolescents, so people like 15 to 19. When we're talking about pediatric bipolar disorder, or at least some people refer to it as pediatric bipolar disorder, we're not necessarily any longer talking about discrete episodes like I was just talking about a few minutes ago. It may not be that you have an episode of depression back to normality, an episode of mania or hypomania back to normality. That's what you would see in adults. But with pediatric bipolar disorder, so we're talking about kids like 10 and under or 12 and under, we're seeing some proponents of it are suggesting that it manifests as more persistent and much more mixed episodes, or mixed in their presentation, I should say. So tends to be a lot more irritability, a lot more mix in the symptoms, so that you'll have both the depressive and the manic symptoms co-occurring together within the same period of time, and a lot more rapid cycling, so shifting in and out of maybe normality and abnormality, so to speak. There's a lot less evidence for inter-episode recovery, so that it's not people with pediatric bipolar disorder or people that believe in that would argue that there's less of a return to a normal baseline, and it kind of continues throughout. People will shift constantly between maybe a manic episode and a depressive episode, or shift frequently between them, or rapidly, I should say. Now, there's problems with this chronicity. If this is happening all the time, and I said just a couple minutes ago that one of the hallmarks of bipolar disorder is this idea of inter-episode recovery, and we're not seeing this in pediatric bipolar disorder, there's questions about, is this really bipolar disorder? Perhaps it's something else that shares a lot of symptoms with a manic episode, or a lot of characteristics. So there'd be something like ADHD with the hyperactivity, the inhibition, or disinhibition, I should say, and distractibility. Maybe it's something like conduct disorder, where somebody's not listening to the rules and it appears that they're being hyperactive and so forth, but in reality they're experiencing a conduct disorder. Now, this isn't to say that pediatric bipolar disorder isn't a real thing. It's just to say that it's not an official diagnosis, but it's something that there's a lot of research being done in right now. That said, it's kind of a controversial area. But importantly, due to this difficulty or the lack of specificity or specific diagnostic criteria in DSM for pediatric bipolar disorder, it's thought to have questionable validity, and many practitioners are very hesitant to diagnose bipolar disorder until later adolescence. So often you'll see people will receive a diagnosis of something else that's less stigmatizing, or carries less stigma and weight with it, something like ADHD, or even a conduct disorder, or oppositional defiant disorder, as opposed to a bipolar disorder. And often if it persists going forward, then they might shift the diagnosis to a bipolar disorder, but especially for younger children, many clinicians, in fact, most clinicians will hold off on the bipolar disorder diagnosis until later on, okay? In terms of prevalence and course, in adulthood and adolescence, that's an embarrassing typo. We're talking about 0.5% to 1% of the population is going to experience bipolar disorder 1 or 2. I did pull the specific prevalence for bipolar 1 and bipolar 2, but this is any type of bipolar disorder. Now, with regards to childhood prevalence, as I was talking about before, if the diagnostic criteria are kind of questionable, or the validity is questionable, it's hard to do prevalence studies, and for that reason, childhood or pediatric prevalence is pretty unclear. There's no clear gender differences, this is in contrast with something like a major depressive disorder, where we see a much greater prevalence of females with major depression. There seems to be no differences in the rates between males and females. Typically, we see onset in adolescence. Peak age of onset is between 15 and 19 years old. It tends to go down a little bit after that, but you're still seeing onset into the 20s and so forth. Sometimes you'll see onset before 15. However, an onset of bipolar disorder prior to age 10 is very rare. Very rarely you're going to see it. And in fact, I'd very much question that diagnosis if it came across my desk. I think importantly, it should be said, I'll get to that in a second, actually. Typically, it's chronic. I mentioned that before. Even though it's episodic, it's chronic in the sense that if you've had a manic episode or a hypomanic episode, you're likely to experience another one at some point in your life. In fact, research is showing us that up to 80%, so for every 5 people with bipolar disorder, 4 of them are going to go on to have a relapse, another episode, in the next 5 years after their initial episode. Often people will graduate diagnoses from something like a major depressive disorder to a bipolar disorder following a manic or hypomanic episode. So you'll have people that have experienced depressive episodes earlier in their life, and then maybe later on, they will, sometime between 15 and 19, let's say, they'll experience their first hypomanic or manic episode, and at that point, they move from having a major depressive disorder to a bipolar disorder. Now, importantly for this, and importantly and quite sadly, frankly, there's frequently a 5 to 10 year lag between the onset of symptoms of mania, hypomania, kind of the core symptoms of bipolar disorder, and recognition of it being bipolar disorder. So the diagnosis often lags 5 to 10 years after the first onset of symptoms. And for this reason, we're seeing people that are going without treatment and experiencing a lot of problems in their lives, both with their individual lives, but also within their family lives and their social lives, their occupational lives, and it causes a lot of problems for people. It's often misattributed to, like in cases where you do have this lag, it's misattributed to the manic symptoms or hypomanic symptoms are attributed to puberty. We've all been through puberty. We've all experienced mood swings in puberty. Most of us are not diagnosed with bipolar disorder. And for that reason, a lot of times these symptoms that people are seeing, they're just a teenager, they'll grow out of it, things like that. Unfortunately, this isn't the case for everybody, and sometimes this is beyond something that's a typical normative mood swing that we would see in puberty, and it should be elevated to be recognized to the point of being a manic episode or a hypomanic episode. I also wanted to mention here, importantly, without treatment, episodes can last approximately 4 to 6 months. Now, that's I don't know about you, but going back to those manic or hypomanic symptoms, let's look at the manic symptoms. Having these kinds of symptoms for 4 to 6 months is not only sounds just frankly exhausting, but there's a lot of damage you can do to your life and to the relationships you have with others in that period of time if it's going on for 4 to 6 months. And it's it is out of your control when that's happening. So it's really important that we're putting in place systems or access to care, and just as importantly, diagnostics, to ensure that people are getting the treatment and the care that they need as soon as they need it. And we're able to recognize when people are experiencing these things. All right, so let's briefly talk about comorbidity with bipolar disorder with regards to adults and adolescents. A very high comorbidity with anxiety disorders, as well as substance use disorders. Now, with regards to substance use disorders, I'm not specifically familiar with the research, but I know that there are arguments about whether a substance use disorder is not necessarily a precursor to bipolar disorder, but rather we're seeing it before diagnosis of bipolar disorder, more for the point that people are kind of self-medicating or trying to treat themselves, or they're engaging in impulsive behaviors due to the manic symptoms that they're experiencing at that time. With regards to the pediatric bipolar disorder that we talked about before, comorbidity is less clear just because the actual diagnosis is kind of up in the air in terms of validity at the time. That said, there is research supporting the idea that pediatric bipolar disorder, so these would be the kind of modified bipolar disorder where it's more persistent, less episodic, and so forth that I was talking about earlier, seems to be highly comorbid with ADHD. So 60 to 90% of children, 30% of adolescents, highly comorbid with ODD and conduct disorder, up to 80%, anxiety disorders, as well as substance use disorders. So this perhaps is unsurprising. These ones here, anytime we see comorbidity this high, it really raises a question of how distinct are these disorders? If 9 out of every 10 kids with pediatric bipolar disorder are also diagnosed as having ADHD, are these really different disorders, or are they the same thing? I don't have the answer for that, but it's a question worth asking. It's a question worth considering. I don't think I have anything else I want to talk about here. Let's briefly talk about etiological theories. the biggest area that there's been the most research done, I think it's fair to say, with regards to bipolar disorder, both in adults and adolescents and children, is the biological side of things. This is a disorder that's considered to have a very large genetic component to it, much stronger genetic role or influence than major depressive disorder. I think within twin studies, it's something like if you have an identical twin or a monozygotic twin that has bipolar disorder, you have a 65% chance of having it yourself. So it's quite highly heritable. That said, as far as I am aware, there's no individual genes that have been consistently implicated. And as I kind of referred to earlier in the course, anytime we're talking about genetics, about something complicated like human behavior, or as complicated as human behavior, including mental disorders, it's very unlikely that there's going to be a bipolar gene, a schizophrenia gene, a depression gene, a whatever gene. It's much more likely that there's going to be hundreds, if not thousands, of different genes that play small roles in contributing to risk for these disorders. And that's going to be true for bipolar disorder as well. Okay. Another thing in terms of just explanations for bipolar disorder is this idea of expressed emotion. This is an idea, or expressed emotion basically describes, typically within family settings, a high degree of communication of disappointment, frustration, criticism towards the family member that's experiencing bipolar disorder. And what's been seen is in families where there is a high degree of expressed emotion, typically negative emotion, like I said, criticism, disappointment, so forth, those families, those individuals in those families tend to be much more likely to experience relapses of manic and hypomanic episodes, and more regular relapses and more severe relapses. So this is one of the reasons that psychotherapy approaches tend to focus on family-based treatments, or often focus on family-based interventions, because the family can play a huge role in either contributing to the risk for relapse or preventing risk for relapse or reducing it at the very least. There's also been research showing that there are personality factors involved with risk for bipolar disorder, including individuals with very high reward sensitivity or sensitivity to rewards tend to be at relatively higher risk for developing a bipolar disorder. And then those with a high drive for achievement, or their families have a high history of achievement, tend to be at relatively higher risk for developing bipolar disorders. Okay. Finally, with regards to treatment, medications, this is in contrast with what we've been talking about for many disorders throughout the course. Medications continue to be the first line treatment for bipolar disorder, especially with symptom management and symptom reduction. When we're talking about mania and hypomania, mood stabilizers like lithium and less often atypical antipsychotic medications are the first line of treatment for these disorders. This is both in adults and children and adolescents. There's certainly, and I've beat this drum already a million times, even today, there's a lot less research in their effectiveness in children, but they still are used. With regards to psychotherapy, research is generally lacking in terms of bipolar treatments, both in adults and adolescents relative to other disorders. This is largely due to a historical focus on biological etiology and treatment of bipolar disorders. There is some evidence that CBT-based approaches can be effective for preventing relapse and recognizing episodes before onset, so you can do some preventative work and kind of stabilizing somebody's mood before they go beyond hypomanic into a full manic episode, or even into a hypomanic episode. And then also I mentioned earlier that family-based treatments play an increasingly important role in the treatment of bipolar disorders. They go into more detail about it in the textbook, so I encourage you to take a look there. I think that's everything I have to talk about today. I want to thank you guys, anybody that tuned in, and best of luck moving forward. Sorry that the the course wasn't able to continue in person. I was really enjoying the lectures and running the course. Unfortunately, it's kind of out of our hands. Hang in there, everybody, and best of luck.